Good morning. Happy Friday. I have Neuro Coffee in hand and it is perfect. All right. For those of you in the 2-week sprint, this is your review and reflection weekend. Time to break out your notebook, make sure that all of your projects are on track and you're making the progress that you desire. Reflection, important. One of the most important things for learning as well. Digging into today's Q&A, this is with Zach. So Zach's working with an offensive lineman playing American football, for those of you outside of the United States. He's got pain with bench press with a barbell. So I believe, if memory serves, he was having like shoulder pain where, say, pec major might attach with the bench press. But when he uses dumbbells, he doesn't have that pain. And so what this question allows us to do is break down a few things about bench pressing, about offensive linemen, little things like that, but a lot of technical issues associated with the difference between a barbell and the dumbbells, and then how the barbell limits our capacity to access certain spaces, and then how we produce force. And so a little bit of powerlifting mentioned in this as well. So those of you who like to just talk about bench press, like to do bench press, or like to learn about bench press, this is going to be a good question for you. So thank you, Zach. Everybody have an outstanding Friday. Make sure you go to the YouTube channel, check out the Reconsider podcast with yours truly and Chris Wykus, and then we will see you next week.
So offensive lineman that gets bilateral, like what he calls like pec pain, kind of like right in here on either side.
Doing what?
Like bilateral, like pec area pain. Anytime he gets over 200 pounds barbell benching, which for him, he says is a weight he should be able to do for like 10 to 15 reps. I think he's leaving me 2 clues in his history, and I think I can figure out one of them, but not the other. So the first is he can go as heavy as he wants dumbbell with no symptoms. And when he does that, he's kind of like, he benches like more like at his side. The other thing that he says is that if he like pushes himself on the barbell to struggle through like a rep a little bit from a difficulty standpoint, left arm pretty much always locks out first. And like the bar is almost tipped to the right as the right arm finishes through. So just want to like confirm my thinking a little bit for the first part of that. Like it just seems that with the dumbbells, he's able to keep the ER space and he can get a yield through those tissues, versus the barbell locks him into IR, and then couple that with like up to a certain weight, the motor output interferes with the yield also. Is that an accurate interpretation of that first part of it?
Okay. To descend the bar to your chest. All right. What do you need first?
In terms of what?
Okay, so I gotta get we're using a barbell first. Okay. So for me to lower the bar to my chest. Okay.
Mm-hmm.
What do I need? Like I have to have the capacity to get the bar to my chest?
Like I need to get eccentric orientation of like everything anterior now. Not sure.
I am moving into a space.
So I need the ER space initially.
Yes, sir. Okay. So what does a barbell do that dumbbells don't?
Takes away a lot of the ER.
Absolutely it does. Absolutely it does. Right? I am fixing my hands in an internally rotated position by holding onto the barbell. So this is one of the reasons why one of the first things you do when people come in with like hip and shoulder pain is that you take away barbell exercises, because they immediately reduce your capacity to access ER space. That's why the dumbbells are more comfortable, because what he can do is he can compensate for his inability to access ER. So he orients more into ER, and now he's less symptomatic. Okay. You see it?
Yep.
Okay. Now, when I'm pressing out of that ER space, what do you got to use?
The IR.
IR. And that's the compression anteriorly. Okay. But what you're going to have to do for him to access that space, you have to get the ER. Now, here's the problem. He's an offensive lineman. Okay. He's laying on the bench and he's got a big heavy weight in his hands.
Yep.
And I bet he arches his back a little bit. Right?
Mm-hmm.
Yeah. Okay.
Yep.
So you've got to, this is one of the reasons why you'll see the big differences in do you read any of the powerlifting literature?
Not.
No. Okay. Craig Robbins, did you powerlift?
Yes.
Okay. I mean, you're just a big, gigantic human muscular guy. So it's like, okay, that's the assumption, right? If you're tall, you play basketball. And if you're a big muscular guy, you're a powerlifter. Classic West Side Louis Simmons recommendation for upper extremity position in a bench press would be what?
Shoulder blades depressed as much as possible.
What would be the angle of the humerus relative to the midline of the body? Do I want my elbows out here, West Side style? They teach the elbows in position, right?
Yeah, I mean, I guess I would teach probably elbows need to stay under the wrists, and depending on where your touch point is.
I'm not disagreeing with you. I'm just saying like the big power lifters, right? That they don't want to tear pecs and stuff. They tend to bring their elbows towards their sides more when they're bench pressing.
Yeah, and hit the lower
especially West Side, because they're probably using like shirts.
Yeah, exactly. So I was literally gonna say to Zach is tell your offensive lineman to take the bench press shirt off. And I know he's not probably not wearing one, but he's benching like he probably has one built in. You know what I mean? He's getting the compression that he would get from the shirt. So what he's able to do, Zach, with the dumbbells is he's able to position his arms to create a more ER oriented humeral position.
Right.
That buys him a space to descend into. Then he can use his IR to press the weight. Okay.
Mm-hmm.
So you've got to get him some more legit ER, okay? Because it's disappearing.
Yeah.
Rather rapidly. If how big is this guy?
Big boy. He's probably like 6'2", 6'3". Gotta be like 260, 280.
Oh, okay. Yeah, he should probably be able to do 15 reps with 200 pounds. Yeah. So
he should be
here's the thing. Here's the thing about offensive linemen is you kind of want them smushed.
Yeah, but like to the point, like smushed, but not to interfere with what he needs to do. So like find the.
Yeah, because I don't want him to turn well.
Yeah.
Because if he gets turned, then the quarterback is counting how many lights there are on the light poles on the sidelines. Because he's looking up all the time. He's laying on his back. Yeah, so you're gonna have to recapture the ER here, right?
Gotcha.
Okay, he just doesn't have a space to lower the weight when he is fixed in the IR representation. Okay,
that makes a lot of sense. What's going on with the left arm locking out first and like consistently in terms of like as he's completing his bench press? Like it almost. I don't know. Like this, like it almost seems like a representation, like of the oblique that he's on.
It is. It's exactly what it is.
Okay.
Yes.
So it's just the muscle activity that drives him on the oblique is just manifesting through the bar, essentially.
Yeah. Like hold your left arm straight out in front of you, and then hold your right arm kind of straight out in front of you, but lower.
And that's that. I'm just turned.
And yeah, there it is. You feel it?
All right.
Yep.
Very helpful.
Mm-hmm.
Thank you.
You're welcome, sir. Good morning. Happy Monday. I have Neuro Coffee in hand and it is perfect. All right. A quick reminder, the Reconsider podcast is up. This round we are talking about Reconsider weight loss. It is up on the YouTube channel, so please go there, check it out on YouTube. Remember to like and subscribe to the channel. It's also wherever you listen to your podcasts. Digging into today's Q&A, this is with Alex. Alex is working with a patient that has bilateral anterior knee pain, primarily at the so-called patellar ligament, aka patellar tendon, depending on your perspective. Both would be acceptable under the circumstances, but typically what we're dealing with here is a lot of external rotation through the system. So Alex gives us a little bit of a hint where he was talking about certain elements where capturing the right foot position. So we capture this first metatarsal head on the ground and the patient experiences a reduction in symptoms. And so what this tells us is we've got way too much ER in the system. We capture the IR legitimately, and now we can actually reduce the load that's going through the anterior knee. And so now what Alex needs to do is determine what is the sequence of events here. We've got a relationship from the proximal femur to the distal femur that has to be accounted for in regards to the differentiation between ER and IR. We also have a relationship between the distal femur and the proximal tibia to address as well. You're going to use a heel to butt knee measurement under this circumstance to help you identify knee position, and then your traditional measures of proximal hip orientation will come into play as well. The key element, we talk about this in the video, is making sure that we're delivering a legitimate relative motion IR into the ground, so we avoid a compensatory strategy, because we can alleviate symptoms with a compensatory IR strategy under some circumstances, but we're not solving the problem. So this is a really good one for those of you dealing with the mechanical anterior knee pain issues. Thank you, Alex. Great question. Everybody have an outstanding Monday, and I'll see you tomorrow.
I am working with a 16-year-old kid
Much
with
better.
bilateral patellar ligament pain. And I had him do like just a depth drop, and he was saying it hurt his knees. And then with getting the first metatarsal head on the ground, it does not hurt his knees when he does the landing. So shocker. But I was curious as to like what exactly, or like the path of the wave as it goes through these structures between those two situations, if you could go over that.
Okay, so think about the structural result. If I take the patella, okay, and I pull it superior laterally, okay, and then picture the attachment of the, and thank you for saying patellar ligament, by the way, that clarifies so many things, which is always nice. It doesn't matter to me in the end, but ultimately it is technically by design a ligament. But think about the direction that it's going to pull. It's going to pull the patellar ligament, right, under the circumstance, and then the twist that it's going to create. Okay, so you're twisting the towel superior and lateral, so it's turning as it's getting pulled superiorly and lateral. Okay, got it?
Yeah, were you just showing like
in my head? I was turning the patella laterally and superiorly.
Okay, is that a left knee?
If the patella was to dislocate laterally, it would be that direction. Okay, and so you got a big twist going through there, right? Which is why it's uncomfortable, right? When he does anything that would be, high force, bouncy kind of a thing, right? You capture the IR, you bring the patella back towards the center. So now you're redirecting IR towards the center of the pelvis. So when you've got this ER representation, everything's going to follow the turn of the ER. We talk about this like with like low back pain, SI joint stuff, and things like that for people that have this proximal ER representation. because that's the direction that the energy is going to go. It's going to follow that ER, and it's going to go around the sort of the backside and pop him in the back, right? Under this circumstance, you've got a ton of ER. He lands on it, and literally that wave is going to pull the patella with it, right? So if you were standing next to him and you grab a hold of his, it's a female?
Male.
Yeah. You grab his patella, and if you pulled it superior laterally, that's where the energy is taking it. And that's where the twist is. Okay. By reorienting it, capturing the IR, you don't have the directionality towards ER. You have more direction towards IR, which again brings all of this force back towards the pelvis. But the thing that's going on is, because you're adding the IR back, the patella is not getting dragged that way. You're not choking off the patellar ligament, right? You're actually giving it slack. It's not really slack per se. It's just a reduction in tension, right? You're giving it, number one, more extensibility, because it's starting from a less lengthened position, right? You gave it the capacity to yield. So now you have a distributed force through the patellar ligament.
Okay, so as he lands onto the ground and his knee bends,
Yes.
if he's not capturing the first metatarsal head, he's starting from a pre-tensiled twist through the ligament. As the knee bends, it has just less available extensibility, and then you're going to hit that full tension pain experience there.
That is correct, sir.
Okay, so you get like a little bit of untwisting just by getting the appropriate joint positions.
Yeah,
and
so
that might buy enough.
Okay, we can use, I'm going to say it wrong again. Is it Yuja? Tell me again. Yuja.
Yeah.
Okay, we're going to use Yujia's question. Okay, where we're talking about the differential between the ER and the IR in the femur itself. Okay, when you don't capture first metatarsal head, you have the distal femur that's getting dragged towards ER, which is what's bringing everything with it relative to the tibia, right? So it's still pulling everything towards ER. Tibia is coming too. It's just that the femur is getting dragged way out with it. That's bringing the patella with it. By capturing first metatarsal head, you're going to bring that distal femur more towards the IR representation, which is what's going to redirect the energy towards the center of the pelvis.
Okay, yeah, that makes sense.
Yeah. So you got a little untwisting to do, because here's what you don't want. He could still use a compensatory IR strategy and probably alleviate symptoms. Got to be careful.
Like what?
What do you mean? Like what?
Like compensatory IR strategy. You mean like arches back?
Yeah, yeah. He could still create an IR substitution that would prevent the wicked ER from taking the patella so far laterally, right? Okay, so you just got to be careful that, and again, your measurements will lead you, right? They'll tell you when you're capturing the relative motions. You just got to be really, really careful. Like don't get like excited about, oh, we captured a whole bunch of IR. Did the ER change? Well, not really. Right? You know what I mean? It's
right.
Like, because again, it's like he created a substitution that alleviated a symptom, but did you solve the problem? It's like, maybe not. So just be careful with that.
Right.
Okay. But yeah, you got the right idea. Good morning. Happy Thursday. I have Neuro Coffee in hand, and it is perfect.
Morning. So I'm trying to be like lazier about doing table tests, i.e. not doing them much. So when you're making the turnaround from bringing like a wide back on the right to going on the oblique, I'm trying to get a better visual representation for like what I should be able to see when I can just make the next move. So let's take like a cable chop, for example. Is it more than just getting the foot contacts and seeing that they can be comfortably on their heel? Or is that more like just the starting conditions I need to bring it back?
What would
Have
be
to take a
yeah.
few breaths and like see the sacral base move back?
Okay, hang on a second. So do you want the sacral base to move back when you're bringing a wide back on the right-hand side first? Ian says no. So he's helping you.
I'm going to go with Ian. I mean, we're getting IR, so I guess.
Where do you need the delay to be first? So let's just say you got a wide ISA that is also forward on the right-hand side. So he's lost the right hip IR. Okay. So we're going to try to bring him back on the right-hand side to drop that center of gravity towards the right heel. Okay. If you capture a good foot position, you've got a really good shot at achieving your goal. But what would be the representation in the pelvis that you would be shooting for here? Do I want a sacral base to counter-nutate, or do I want to create a delay in the posterior outlet?
Probably the outlet.
There you go. So that's going to be the association that you want to start to make on that right-hand side before you try to make a left-hand turn. Okay. You follow?
If I get sacral base, am I just orienting them?
If you get sacral base to what? To
heel. Sorry.
Okay. So under what circumstance? So if you've got a foot position to capture the right medial heel, okay, and you're trying to capture the IR, and you get this, and you see the sacral base moving posteriorly.
I would guess that's probably just an orientation driven from like the lumbar spine.
There you go. So you tilted.
Yeah.
You tilted the pelvis backwards.
Yeah. Okay.
Yeah.
That makes
So
sense.
that's not, now it'll look like you can capture the foot contacts because you're still making a space to drop the foot down inside. Okay. But you're not going to recapture your relative motion at the hip. You see it?
Yeah.
Yeah. So this is why you got to be a little bit careful. This is why table tests can still be helpful. Right. But I mean, you don't have to use them, but like if you have a question in your mind, that's when I would go back.
Right. Yeah. So I'm just looking to see the outlet open.
Yes, sir. Yes, sir.
Okay.
Yeah. It's like if you were to watch them squat, after you do that activity, you would see it.
Like it would open more as they descend.
Yeah. And to be honest with you, it may actually track them to the right. Like
the squat.
Yes, they may actually shift towards their right side as they descend. Because you're getting
the other outlet to open in that situation.
No, you're getting the right posterior outlet to open, so they're gonna move in the direction of expansion. Simple rule, day one, intensive, first hour. Okay. Why would
that move them left?
No, not left, to the right.
Oh, you're saying the squat would also reinforce the move.
Yes, I'm trying to do this without a table test for you, and for everybody else that doesn't do table tests, it's like, oh, I see them squat, and I see the pelvis, the posterior outlet expands, and they shift into that right side as they descend into the squat. It's like, oh, there's my cue. It's like, okay, now I got to turn them.
Right.
Okay. Now, question for you: so there's a lot of people that will squat. And they will appear to shift to the right, okay, and it's something that would be indicative of the fact that we don't really like that type of a squat, because it would be also indicative of the fact that they're lacking hip IR on that right side. So I can have two shifts that are similar in description, because people say it's a right shift. How would you know that you have recaptured the hip IR? So you get the sacral or you get the posterior outlet expansion. They shift in that direction, but how do I know I got the right one versus the wrong one?
The pelvis would not shift forwards on the right side, and the weight would not shift toward the toes, and then it would stay a little bit more like within the base of support.
Boom! There you go. It's inside the base of support.
Because
Okay.
the bad one is kind of like,
Okay. So here's what you're going to see on the bad one. You're going to see an increase in anterior orientation on the right side. You're going to see an increased compressive strategy in the posterior lower or lateral rib cage as the substitution for the IR as they try to descend. And the pelvis will try to scoot outside of the base of support, and they will lose their medial foot contacts. You see it?
yeah.
So this is why you got to be careful when you're describing the so-called right shift in a squat to whomever, because they are not always the same. One can be a representation of, I just recaptured what I was trying to do, it's time to turn them. The other one is, I didn't recapture the medial foot contact that I wanted in the first place. You see it?
Yeah.
Big deal.
Yeah.
Very big deal. Like being able to tell the difference between the two. And then this saves you from having to throw them back on the table. Cool.
Very cool.
Good morning. Happy Tuesday. I have NeuroCoffee in hand, and it is perfect. All right. A very busy Tuesday coming up. We're going to dig straight into today's Q&A. This is the back end of a conversation, so it's a relatively short video. It's the back end of a conversation. We're looking at relationship between a foot and pelvis. And the key element here is that when we talk about the foot on the ground, as soon as we make that ground contact, we're starting to apply internal rotation into the ground. And so it's how we demonstrate that internal rotation that's going to give us clues as to what type of a compensatory strategy that we're going to be using, what type of adaptations that we can expect. And so we can use this foot as a view of how the system is behaving. And so again, it's a very, very short video. It's the back end of a conversation that was much longer, but it's going to have a little sliver of gold in there for you as to how we see this internal rotation going into the ground, why we would see certain adaptations, and where you're going to see certain adaptations. So I believe this is Ian and Paul contributing to this video. So thank you guys for your help. Everybody have an outstanding Tuesday. I'll see you tomorrow.
That would make sense with the pelvis A to P dimensions, because the people who bend the calcaneus have more A to P dimensions versus the people who get the subtalar axis and the really ER to IR bend. They skip the IR quick and land the IR way forward in front of the.
It's again, so I can land it through the calcaneus. I can land it through the talus. I can land it right in front of the. I can land it through the midfoot. I can land it through the forefoot. Right.
Yeah, just
I have
about.
to put on like boom, boom, boom. Like it's going from back to front.
Yeah, got it.
I land here. I got to get IR superimposed on the foot.
Yeah.
Structure determines where that's going to be.
Yes, sir. Understood. Clear. Get it. Thank you. Thank you, sir.
Good. Paul, you okay?
That was a heavy one. Good question.
So hey, Paul, just so you understand, everything that we just talked about is normal. Okay, all of this happens all of the time. The question mark is a matter of degree, right? The longer I apply IR in one place, that's where you start to see the adaptations take place. But all of this is happening, like everything that we just talked about is a normal representation. The bones do this every time you take a step forward. Just a matter of degree as to where and when and how much. That's all we're trying to figure out. And it's like, that's why the foot representation becomes so powerful for us, because it tells us, it's like, oh, I know the strategy that you're using from back to front when you land. Like, okay, where do I have an early representation? Okay, cool. Then I usually have a pretty good looking foot because I have the normal representation of IR superimposed on ER. If I got a goofy looking foot, that's somebody that's applying IR into the ground with a prolonged strategy in that area. Simple. Right? That's the simple part. The complex part is dealing with humans.
Yeah, and all the iterations. That was the first time I heard you go through the foot with that much level of detail. So that was awesome.
Good.